maybe some extra-articular pathology, strains, or just, really a lot of times we really didn't know what was going on. And so hip conditions have also gone up in the media with pro athletes, undergoing these injuries. And so now patients are really understanding that there's pathology that goes on in the hip. Labral tear is a big buzzword. A lot of times patients are looking for that. And then we have ways to treat the conditions now, whereas before hip arthroscopy, before these open hip dislocations and, with Dr. Gons and everything, it was, we really didn't have a way of treating these conditions. And this kind of goes along with that, is that previously, especially for athletes, these conditions were really just diagnosed as strains and sprains. And, you've got a flexor, we got a flexor tendon problem or whatnot. And, 60% of athletes that these intraarticular disorders, things that were eventually found to be intraarticular, were really misdiagnosed as an extraarticular problem. So things like labral tears or impingement or cartilage damage would have been considered a strain or a psoas problem before. And then it takes a while for that to get diagnosed. And I think we're doing a better job of that now, being able to delineate those intraarticular pathology from the extraarticular. But overall, hips, and I tell patients this all the time, hips are difficult. And if you just look at where the hip is and what's all around that, there is so much that can cause pain in that area, whether it be a GU problem, GYN problem, GI. There's all this, pelvic floor musculature that can play a role. And then, of course, from the MSK standpoint, you've got spine issues that can definitely give you pelvic pain and pain around that same area. And then all of the non-spine issues, which include, when a patient comes in with a complaint of, say, oh, it's my hip, it could be any of these things. It could be a proximal hamstring problem, trochanteric, like all the gluteal lateral base hip problems that they see, gluteal tears, trochanteric bursitis, IT band issues. There's a whole issue with the piriformis. A lot of times I'm not sure what to do with that. Ischiofemoral impingement, psoas and rectus problems in the front, core muscle injuries and sports hernia. And then, of course, there's the intraarticular pathology, which I end up focusing on primarily, where, FAI, instability, arthritis, and then osteonecrosis or AVN. So, and that's not even an exhaustive list. So when you just look at the MSK part alone, you have a huge list of pathology, and that doesn't even include all of the other non-MSK problems. So hips are very difficult to kind of narrow down. So I think that's I spend most of my time with a patient trying to determine that the hip is the center, the etiology of the pain, and really honing in on that diagnosis. I think it's so important with hips. Now, this is how I kind of approach hip disorders. And first of all, I just start with this question: is it the hip? And that's when I'm really trying to narrow down for the first, when the patient walks into my clinic, is this coming from the hip joint or not? And so in ways to determine that, provocative maneuvers can be very helpful. So if the patient has pain when you're moving the hip around, and that's recreating their symptoms, that can help localize it to the hip joint. Lack of radicular symptoms. So if the patient starts talking about, well, I've got pain that it runs all the way down the leg, especially posterior pain, then it starts to pique my interest more towards the spine. I had a patient yesterday. They came in, they had a hip scope and was doing really well after the hip scope for about 4 to 5 months. And then they started having this new pain. It was posterior pain. It was running down the leg. And they had gotten all these MRIs of the hip, really focusing in on the hip joint as being the issue. But at least in my mind, the highest thing on my list was spine pathology or spine etiology for that pain. So that can kind of tip you off a little bit. Is this really come from the hip or not? And then a history of injury or in their history of pain and how they present. All of that's very important to kind of pointing towards a hip pathology or not. And then the next goal is to really determine is, okay, we think it's coming from the hip joint. We don't think it's a spine. We don't think it's a GYN problem or something like that. Then we're trying to figure out, is this an intra-articular problem? Is it something with the labrum, with impingement, chondral issue in the joint, or is this an extra-articular problem with the psoas tendon or the rexus tendon, or any of the lateral-based problems that we see? And it can get confusing because hip pathology itself can coexist with this extra-articular pathology. And the other thing that we see is that the longer that a patient has an intra-articular problem, they start to get these compensatory problems. You start to see gluteal pain, abductor pain, and things like that. So just because a patient has posterior based pain or laterally based pain does not mean definitively that it's not coming from an intra-articular source. It could be that this has just been going on a long time. They've been compensating for it, and that's affected the entire kinetic chain, and they've started getting these compensatory issues. Now, these are the intra-articular disorders primarily, FAI, where you have pincer impingement, cam impingement, or mixed type, and then hip instability. And this is something that, again, with how new hip arthroscopy and hip conditions, all these hip conditions are, hip instability is even on the newer end of that. And we're learning so much about how to manage hip instability, how to diagnose it. But hip instability underneath that includes hip dysplasia, and then also ligamentous laxity. I see a lot of patients with Ehlers-Danlos syndrome that come to my clinic, and then iatrogenic hip instability after a hip arthroscopy. And then, of course, there's osteoarthritis and osteonecrosis. And really, all of those, so if a patient comes in with a labral tear, and a lot of times that's how they're sent. They had an MRI and said, okay, I've got a labral tear, and they're focused on that. All of this pathology could involve having a labral tear, including arthritis. So it's really important to get to the bottom of why they have the labral tear and what's the underlying pathology going on. I would say in most cases, if the patient has a labral tear, the reason for it is either impingement or instability of the hip. And I usually try and figure out which one of those that I'm dealing with, if I think it's truly an intra-articular issue, and if I truly think that labral tear is a source of their pain, then I start looking for, okay, what is the reason that they have a labral tear? The chances of having a labral tear without some sort of underlying pathology is pretty rare. Now, so impingement, just to kind of go over that a little bit, is we have pincer impingement, which is where you just have an extra bump over the top of the acetabulum, so a little bit of over coverage of the acetabulum, and the cam impingement, where you have that bump over the head neck junction, or decreased offset even of just the head neck junction. And the primary complaint that we see is that we have constraints of range of motion. On exam, you see that anterior impingement signs on exam. The things that I see pathologically when you have pincer impingement, usually you have an issue primarily with the labrum. So if I have a patient that has a big pincer, I know that labrum is probably going to be pretty diminutive when I get into surgery. It may be a patient that we may not be able to repair their labrum. They may have to have a labral reconstruction at a later time. Whereas cam impingement are the patients where we see a lot of that early cartilage damage right at the chondrolabral junction. Because of the nature of the pathology, you get more cartilage damage with cam impingement. This is just kind of what that looks like there. Now that cam impingement also is kind of, most of the time it's that anterior kind of superior area. So not directly lateral, but usually it's more anterior based. And that's why when we'll talk about our imaging later, why we see it on certain views and we don't see it on others. And this is what pincer impingement will look like. This is an open hip surgery, and you can see that over coverage of the acetabulum, and you see just how diminutive this labrum is. It's just, very kind of, and this probably even looks better than most labrums with pincer impingement. And now you can see where that's been resected. And here's cam impingement. So you can see that the head is not round. There's that increased bone at the head neck junction. And so you can see before and after where now you have good clearance, good nice spherical head, whereas before that wasn't present. And again, labral pathology, whenever I see a labral tear, I'm always looking for, okay, what's the real cause of this labral tear? And most of the times I end up with that going into one of two categories. Is this an FAI issue, or is it an instability issue, like a subtle instability issue associated with either a ligamentous laxity or an osseous deformity of the hip, some borderline hip dysplasia or gross hip dysplasia, that the hip is subluxing out and damaging the labrum along the way. So presentation of these patients, a lot of times they don't necessarily come in with trauma. This has just kind of been going on for a long time. Don't really know how it started. Now, it is nice if they do have an acute injury, a traumatic event, that can be a little bit more favorable in terms of as a prognostic indicator. Same thing with mechanical symptoms. They got popping, catching, sharp pain in the hip, then that can also be a good indicator. A lot of times this hurts with twisting motions. One I hear a lot of times is that, well, it hurts when I sit for a long period of time. It's really those activities where the hip is in deep flexion or flex for a long period of time that we see as most of the exacerbating features. And then in terms of localization, it's the classic hip pain, classic intraarticular pathology, especially FAI, is anterior based pain right in the groin, right in the crease of the thigh there. That's primarily, if I see that, then I'm really starting to hone in on the hip. Patients a lot of time will give you the C sign, where they will cup their hand around the hip joint, so kind of right over top of their greater trochanter, and they'll say, yeah, it's somewhere deep inside of there. And when I do that, again, that's a very high indicator for that. This is an intraarticular pathology versus something else going on. Now, again, posterior pain, I see a lot of patients that have posterior pain. Sometimes they can have impingement that is posterior, but a lot of times that I see this, it's either a non-intraarticular source, or it's just a compensation that we see that they do truly have intraarticular pathology, but this is a compensatory problem. And a lot of times that we see these, they're not in isolation. So a patient will say, yeah, I've got pain right in the groin. That hurts when you do the provocative maneuvers, but they also have some posterior based pain as well that they report as separate. And so you kind of have to dig into that a little bit. And this is that C sign there, where they just kind of take their hand and cup it around the hip. On examination, log rolling, it's very, very rare that I find a patient that has a positive log roll. If they do, it's very specific for intraarticular pathology. More commonly, I see patients that present with flexion and adduction, and pain with flexion and adduction, internal rotation of the hip. That's really the main physical exam maneuver that I'm doing, that I'm looking for to elicit pain and to elicit the same symptoms that they're having. So say they have most of their pain is, say, either laterally based or posterior based, or they have it in their mind of what that pain feels like. And I flex the hip up and I internally rotate it, and they kind of wince a little bit. And I ask them, okay, where did you feel that? Did that recreate the pain? And they say, sometimes they might say, no, that's not the pain that I'm having, but that hurt in of itself. So that could kind of point to, well, maybe they do have some impingement, or maybe they do have some intraarticular type pathology, but it's not what's giving them most of their pain most of the time. This is not what they're feeling on a daily basis. So it's really important to sift through that to find out exactly what their pain is. Sometimes you'll feel a click and things like that. And you can do different areas of impingement. So most of the time it's an anterior impingement. So you bring it up and you add flexion, adduction, internal rotation. That's where you'll feel it. But you can also flex and then kind of bring the hip out into some external or bring it abduction and then also internal rotate again, kind of bring the leg down to the side of the table. And that's where you get some more of that posterior impingement. And frequently that'll be positive with patients as well. Now, determining this intraarticular, extraarticular pathology can be very, very difficult sometimes, even with all those, the examination can be very similar and their history can be very similar as well. Some signs that I look for to try and say, okay, is this more of a tendonitis or tendinosis problem going on with the hip flexure? Tenderness over the psoas erectus tendon, that can be very helpful. And that can kind of point towards more of an issue going on with that. Pain with resisted hip flexion. So if I have them force, their hip up against my hand, either with the hip, the knee extended or the knee flexed, that can point towards more of a rectus or a psoas problem. If they truly have a internal snapping of the hip, where you bring the hip up from abduction and external rotation into internal rotation, adduction, and you feel that big pop as you do that, that can be a sign of a snapping hip or a psoas snapping over the top of the hip joint. A lot of times these symptoms are short-lived. So it hasn't been going on for as long. It's maybe an athletic injury that they've had. Usually it's activity related. But a lot of times it does still require more information. I can't really make the diagnosis alone based on that information. And the other thing is, that's not a great picture here, but always get a Baton score. So it takes you about a minute or less to just ask these questions. Is really important to point towards is there an instability issue going on? And even if there's not, even if it's primarily that I'm thinking that it's an impingement issue, it really tells me if they have ligament laxity to be a lot more careful when I'm dealing with a capsule at the time of surgery. And Dr. Job says, as he says, that really the gold standard is your history and physical. So the MRI is really, that's kind of more convincing the patient, more convincing the insurance company that there's an injury going on. Really, your examination is really, and your history is the most important thing. And I can't stress that enough. Followed by the X-rays. Really, the MRI is kind of the least important thing when it comes to diagnosing these conditions, at least in my opinion. Now, we got when you're getting radiographs, you're going to start with the AP pelvis, and then the views that I normally get, I get an AP pelvis, I get a modified done, okay, lateral, and then I'll get a false profile. A lot of times I'll see patients, they'll come in, they'll have a straight frog leg. And when you do a straight frog leg, what it can sometimes do is it misses that cam impingement because the leg is too externally rotated. So you're seeing a true lateral of the hip, and you'll miss that kind of anterior lateral portion where you actually see the bump. So, and I've seen this, not infrequently, a patient will come in with that frog leg lateral, I'll end up getting a modified done, and then all of a sudden we see that bump that we didn't see before. So that's really important. You can see the crossover sign. I'll go through all this. There's a large cam lesion there. So again, don't forget the modified done. Now, these are the measurements that I make normally when I see a hip patient. It takes a little bit of time, but it's important to make these measurements. Your alpha angle, so I just draw a circle around the hip joint. And then for the center edge angle, that's just a line from the vertical to the lateral edge of the acetabulum. And that's going to tell you how deep the socket is. Essentially, we're looking for anything greater than 25 there. Anything less than that, we're kind of getting into some borderline instability. And that's really important to stay out of trouble with that. You can have acetabular inclination. We're looking for really anything less than 10 there. Crossover sign. So crossover sign, there's a little bit, this in my practice, it can give me a hint that maybe there's some pincer impingement going on, but I don't rely on this exclusively to really diagnose FAI. It's not as clear to me, pincer pathology diagnosed based on a crossover sign is not as clear as if I see a big cam lesion. And I'll talk about that in a little bit. And you can quantify that as well. It really depends on if they're laying down or not, whether you kind of how you're visualizing if you see a crossover or not. You can see ischial prominence, so you can see if you see that ischial spine. A lot of times you don't see that, and that can again tip you off that there's some acetabular retroversion going on and anterior over coverage. And you can make your alpha angle. So again, you just put a center of the head, make a line parallel to the neck, and then where does it lose its spherosity? That's where your alpha angle is. And again, I'm looking for really anything greater than 60. Some would say even less to diagnose FAI. And sometimes it's not as obvious, and I'll show you some examples later. You see, it's not a big bump, it's just some decreased offset of the hip joint. And this is what those x-rays look like when you're taking them. So you can share this with your radiology tech if they don't know how to take them. The modified done, very easy to take. You can do two at the same time if you have thinking of both hips, and then your false profile there as well. A little bit more difficult to get your false profile, but not difficult views to get, and it makes a big difference. Now, when it comes to MRI, there's a lot of discussion on, okay, do you need an arthrogram or not? And what I would say is that I really like arthrograms. I think they're very helpful. The other thing that I like to do if I send a patient for an MRI is a lot of times I'll have them put, I like the fact that they're putting local anesthetic into the hip at the time of the arthrogram, and that gives us really good diagnostic information. If a patient went for an arthrogram even before they saw me, and I'm looking at the image, I'll ask them, I'll say, did the hip feel better at the time of the arthrogram? When they put that numbing medicine into your hip, did it take your pain away? At least for, a few minutes or 5 minutes or so. And sometimes patients say, yeah, actually it kind of it hurt for a second, then it felt better for a little while, and then the pain came back. That's a really good diagnostic indicator. And that's a additional diagnostic test that you got a free diagnostic injection associated with the arthrogram, which that can be really, really helpful. The other thing too, if a patient's not ready for, we're not really thinking that they're ready for surgery, or then you could also have them go ahead and put in a cortisone injection at the same time as the arthrogram. And sometimes I'll do that. Less frequently, but sometimes you have the ability to do that as well. Again, to give you the diagnostic information, but also to kind of try and give some therapeutic relief as well. You can see indirect evidence of issues with the labrum and paralabral cyst and things like that, in addition to just having labral tear. And that can be really, really helpful to help diagnose it. These can be very subtle on MRI. And a lot of times I'm kind of looking at it and I'm blurring my eyes a little bit. And I'm like, yeah, I think I see something there. And I think that's the way it is for most people. But usually if you kind of look at it closely enough, you'll be able to see something. Additional views, and we don't have them here. It's something that I've been looking into, maybe trying to get, is radial cuts of the hip on the MRI. And that can be really helpful as well. And you're kind of looking at it at each clock face. Do you see a labral tear? And that can kind of be more sensitive to diagnose a labral problem. Now, if you're going to get, I like MRI arthrogram, but if you are going to get just regular MRI, really recommend getting a 3T MRI. And that's when people have been comparing arthrogram versus non-arthrogram. Really, if you get a good 3T image and there's not a lot of motion, that can also be very helpful as well. And I won't send them for an arthrogram. I'll be okay based on the images that we have. I do find that MRI is very, very helpful. And for me, a lot of times it's helpful to rule out other pathology. So I've got to have the MRI because, I've got to rule out things like osteonecrosis and major chondral damage and things like that. Even if the MRI says that there's not a labral tear present, especially if it's not a 3T MRI and arthrogram, it doesn't mean that that's definitively not there. And I've seen that multiple occasions where I've been in the operating room. The MRI said that there was not a labral tear, and then we end up finding one intraarticular. And again, 3T MRI and arthrogram are most helpful, while an MRI of like the whole pelvis is not as helpful for diagnosing pathology. So what if we're still not sure? We're still not sure, is this intraarticular or extraarticular? This is where I really lean on our primary care sports medicine colleagues, our PM&R colleagues, to help diagnose these things. And a lot of times I'll send patients over to my colleagues to do an ultrasound examination to really either do an intraarticular injection, diagnostic injection, or if we're thinking that it's more of an extraarticular pathology, inject in that area as well, and then see if the patient gets better or not. If it's intraarticular and we do an injection in that area, their pain should get better. Vice versa, if it's extraarticular and we inject maybe around the tendon or that sort of thing, then that pain should get better as well. And those are very, very, very helpful. The other thing is just doing a dynamic ultrasound evaluation. That can also be super helpful as well. So if I'm not convinced based on my exam and my imaging and everything that this is truly an intraarticular issue going on, then that's where I'll frequently will refer out to one of my PM&R primary care sports colleagues. And I really can't stress that enough of how many patients I end up sending out for that. It's lateral base pain, proximal hamstring as well. There's a lot of things that I see that I really lean on those colleagues to really help diagnose it. And a lot of times it's bouncing back and forth. So I'll send it to them, they'll send it back to me. And it's a really, really good dialogue communication. And that's critical when we're dealing with these patients. What if it seems intraarticular, but imaging's not matching? So say we really think it's an intraarticular source. They've got a labral tear maybe on an MRI, but there's no evidence of substantial CAM or pincer pathology on my imaging. Maybe I've got borderline instability on my measurements, or I have a suspicion for what's called a delta CAM, so like a CAM lesion, but I can't quite see it on the imaging because of the location of it. And that's where I lean on CT. And really it's primarily when I don't see an obvious CAM deformity. Maybe I have a pincer pathology that's present, or I have instability that's suspected. These a lot of times are patients that I'm thinking are moving towards surgery. And I just need more information on trying to determine what type of surgery they need. And then also if I know what type they need, how can I execute that most appropriately? And the CT scan that I get a CT scan with a specific protocol called Stryker Hip Map protocol. And what that does, it essentially gives you a hip map of the hip, or a heat map where there's extra bone. And here you can see really nicely where that pincer lesion is, and which is extremely difficult to see just on your x-rays. And so with me going into the OR, having this available is really critical. Let me know how much to take off, exactly where to take off, and what we're dealing with. This is primarily a pincer problem. And I know that going into the operating room, and that's not always clear before that. The other thing that you see on these measurements, you get all the measurements on the right side, and are we dealing primarily with an impingement problem or an instability problem? If I don't see anything on my hip map in terms of impingement, and everything on the right side is pointing instability, then a hip arthroscopy may not be the best option for that patient. And that's when we start looking at open hip surgeries, PAOs, and things like that. So the hip map is really critical. I do it for any time I pretty much have a patient that doesn't have a big CAM lesion, or a patient that I'm thinking has an instability problem. And then that really keeps you out of trouble. So who's appropriate for hip arthroscopy? Primarily patients that we think there's FAI going on. You can consider some borderline instability cases where they don't have a whole lot of osseous morphology that goes along with dysplasia, but they've got a little bit of instability. Maybe it's something we could tighten up the capsule. No arthritis or little to no arthritis of the hip. So you really need to see good preserved joint space on your standing pelvis radiographs. And it can still be appropriate for patients that are over 50. However, in those patients, I do a lot of times have a discussion on if this pain's been going on for a long time and they have surgery, I will a lot of times discuss the option of a hip replacement as well. Because I do know that in that age, the reliability of pain relief and the function and everything that they want is going to be very, very good with the hip replacement. And will be less reliable with the hip arthroscopy, even if I'm not seeing a lot of significant cartilage damage on my radiographs. We usually will see some of that when we get intraarticularly. So it is a discussion that I at least kind of lay things out to them, say these are the options for you. So here's some cases. This is a 23-year-old college football player. I think he played for Carnegie Mellon, I think previously. So he had right greater than left hip pain. It was located primarily in the groin, worsened with his athletic activities, squatting, sitting for long periods of time, painful popping, graded 2 months of physical therapy. He had an intraarticular injection and gave him 2 days of relief. And again, that's really, really helpful for me. Some people would say, oh, that's a failed injection or that didn't give him relief. Absolutely, that's a positive injection. And that is really, really good diagnostic information. If they got pain relief and it took their pain away for 2 days, we know this pain's coming from that hip joint. It's an intraarticular source, and that is a good prognostic indicator for the patient. I love to see that because I know that I can get these patients better. Here's what the examination looks like. In this kind of way, I usually lay it out in my notes. You have all your range of motion. A lot of times their internal rotation will be decreased. And then, positive anterior impingement signs. Sometimes I'll see positive posterior impingement signs. Those prone anterior apprehension and pubalgia resisted hemorrhage crunch, those are for instability, and then for looking for sports hernia or core muscle injury, respectively. This were his radiographs. So you can see on the AP view, you maybe see a little bit, but not too much going on the AP view. And then when you get that modified done view, you can see how there's really very little head neck offset on either side. And you can see those that cam deformity on both sides. Here's his MRI, 2 different cuts. You can see the labral tear where that fluid's kind of falling into that crest, and you can see a little bit of the damage of the chondrolabral junction up here. Now, this is what his scope pictures look like. So you can see the labrum. Here's the labrum up here, and this is where the labral chondral junction is damaged. He actually had a little bit of an ossicle, ossicromiale right here, and this was a little free piece of bone there on the acetabular side. So this is where the capsule has been lifted up, and we're looking at that acetabulum kind of like right on the roof of the behind the acetabulum there. And this is where I've shaved down that bone right there. And you can see that the labrum, again, is torn pretty much all the way around. And you can see all of the fraying of the cartilage there. And then you can see how we've started to do our labral repair. And this is what the labral repair looks like. You can see this is the anterior superior part of the labrum here on the right. On the left, you're kind of getting towards the posterior part. And you can see all that damage that's been done to the labral chondral junction there. I mean, it's pretty significant in this patient. This is a young guy. And you can see how we've repaired that labrum back down to the bone and secured it with these suture anchors. And then you can see as the hip's coming back into the joint, you can see how that labrum is starting to, the hip's seated back in, and you start to get a suction seal of that labrum again up against the femoral head there. And this is as we've resected, there's this cam lesion up on the top right, and after we've resected that cam lesion. Now this is a tool that I like to use intraoperatively to define how much resection I've done. And you can see pre-op and post-op, we make these measurements before I do the resection. And you can see we take different measurements with the leg and extension and the leg and flexion, and you can really see we get definitive quantitative measurements of where it was before and where it was after to make sure that we're taking off the right amount of bone. And you can really see this is more of the done view when the hip is flexed up into flexion about 45 degrees and some external rotation. That's in this patient where you can really see where that cam lesion is, that anterior superior area of the femoral head neck junction. And you can see how now we've gone from 71 down to 45. And you can see that nice spherical femoral head now versus before there was really no offset there. And that's this patient's problem. I probably could have just left that labrum alone and taken off the bone, and the patient would have felt a lot better. And I can't stress that enough. It's the bone that is the most important part. And if you don't treat the bone appropriately, patient's going to continue to have pain and continue to have problems in the hip, and we're not helping them. I know there's a lot of focus on repairing the labrum. There's a lot of industry focus on repairing the labrum because they don't get paid for just resecting the bone. They get paid by every anchor that we put in. So there's a lot of focus on repairing the labrum or reconstructing the labrum, and it's neat. And there's all these techniques that we can use to do it. But at the end of the day, it's the resection of the bone that's the important part. Here's another case. This 19-year-old lacrosse player, greater than a year of right hip pain in the groin, had a month of rest and insights, positive response to intraarticular injection as well. The pain came back and had 6 months of physical therapy. She had positive anterior impingement on exam. She did have, was pretty flexible. This were her measurements. So pretty much just had a decrease offset on her done view. And you see here, this was a little more subtle. So on the AP view, looks okay again. But again, on that modified done, we're not seeing a big bump there. We're just seeing that there's really just very little offset in terms of the head neck junction there. So again, it's not always really bold and obvious what you see. A lot of times it can be kind of subtle like this. But if you actually make the measurement, it's a high alpha angle. And then her really no signs of osseous instability. And then this is her MRI, and you see this is pretty subtle as well. And I think this was the one that they actually called that there wasn't a labral tear. But I looked at it and I felt like based on her symptoms, based on her X-ray, and it looks like I could see a little cleft there on the images well enough. Now when we get in there at the time of surgery, this is what it looked like, and kind of hard to see in the picture, but she definitively had a labral tear. You could lift up that labrum and it was free along that edge right there. And this is after it's been repaired. And you can see the damage, even the damage that's been done. And this is not from our surgery. This is from that bubbling up of that chondral labral junction there from that decreased offset that she had. And this is after the hip's been put back in the socket. You can see a little bit of that decreased offset at the head neck junction there. And then we resected that. This is a little bit of what the rehab protocol looks like. She was weight bearing and tolerated with crutches immediately. We'll have her here in a hip abduction brace for about 2 to 4 weeks. We'll start PT immediately, working in general range of motion. Straight ahead running is usually about 3 months, and the return to place about 5 to 6 months. And I remember this particular patient, she came back into the clinic without any crutches, without her brace on, and she's just sitting on the table, kind of swinging her leg back and forth. And I'm okay with that. I truly believe that patients are going to limit themselves most of the time. We're doing a robust repair. So I put them in a brace to kind of help protect them, to slow them down a little bit. But every patient's a little bit different. And she went on doing great. She's back to playing lacrosse and had a nice outcome. Last case is 40-year-old truck driver, greater than 6 months of left hip pain, pain located in the groin. Worse when sitting with long periods of time. He did have painful popping, and been seen by a chiropractor, been doing manipulation, therapy, dry needling, and things like that. Really a lot of the things that this particular chiropractor, I think, is also a physical therapist, and so is working, doing a lot of therapy as well, and some of those modalities, which were helping, but just not completely getting better. On exam, decreased internal rotation, really no internal rotation on exam, positive anterior impingement signs. This is a radiographs. And again, you don't see much at all on these radiographs. You see a little bit of that crossover sign. You see a little bit of ischial spine sign there, no cam impingement whatsoever. So this is one that I'm looking at as like, I want to get some more information. MRI definitely shows a labral tear. I got a hip map, CT scan with hip map, and super, super helpful. So you can see now how it really defines out that pincer impingement, and then you can see that that small amount of cam impingement as well. This is a case, and this is what a pincer looks like. It's that this bone is almost just pushing the labrum off, and the labrum is very, very diminutive, and it's just been thinned out because that bone is just kind of pushing it away, and you have to peel that labrum off. You just kind of have to peel it away from the edge of the acetabulum, and then shave down that bone. And then so a lot of times the labrum will just kind of be free floating in the joint, and that tissue really won't be very robust. I was afraid in this patient I wasn't able to get a labral repair, but we were able to get the labrum repaired, got a good repair in the labrum, and he still had enough tissue there. But the main thing is that you get all of the bone removed, because if I don't remove that bone, he's going to continue to have a problem. So I would rather have a labrum that's unable to be repaired and make sure that I got all the bone removed than leave that bone behind and just throw some stitches in there and say, oh, I repaired the labrum and he's in good shape. So so that I was very happy, and you can see how here that pincer's been removed. He's got a nice suction seal from his labrum restored on the femoral head there. And this is a great, I mean, it's a really great case of pincer impingement. You can see right here that how that acetabulum's just been grinding into the femoral head neck junction. And this is it's just put a big groove in the bone right here. And it's exactly where that pincer was located. And we can see that here. You can see where the labrum repair has been done, where that pincer was resected. And then now where it used to be, if you can imagine you flex this hip up a little bit more, this is now going to fall up underneath that labrum and fall up underneath where that acetabulum is. And we've removed that area of impingement, and he'll do well. Last thing I want to focus on is, I get this question a lot, is this dangerous? Is this something that we need to treat? What do we do with patients that maybe are asymptomatic or don't have that much pain? Or is it something that we need to get to quickly? Does it lead to arthritis and things like that? So, there's a study that was done with 337 patients, longitudinal study, patients that went on to total hip arthroplasty in less than 50 years. And they found that evidence of FAI in about 35% of these patients, okay? This was a longitudinal study done in over 1,000 patients, 1,000 women, and they found that every degree increase over 65 degrees of an alpha angle had a 5% increase of evidence of radiographic OA at 20 years. So there's a lot of evidence out there that FAI, and especially CAM type FAI, can lead to arthritis. And usually the way the discussion goes with the patients is I'll tell them this. I'll tell them, yes, there's evidence that this can lead to arthritis, but these studies don't delineate a painful from a non-painful hip. So, it's hard to say where that study is. Are these asymptomatic patients or not? And I would say that in most of those patients, they were not asymptomatic, but they had a painful hip. And then the second thing is that even if we knew that your hip had a higher risk of going onto arthritis if it's not painful, there's no evidence that an intervention that we're doing can reverse that trend at this point. And that we need more information to really say that. So when we use the term hip preservation, we're kind of using the term really in that I'm not doing a hip replacement, but whether I'm actually preserving that joint and putting off the need for a hip replacement, I think that that has not been definitively determined at this point. We think that that's the case, and we think that we're helping, especially in those examples I showed you. We're removing that source of the kind of stopping the bleeding of getting that damage at chondrolabral junction. But the definitive evidence of that, I think, is we still need more information. Generally, in my practice, I generally don't operate on asymptomatic hips. If I did, I'd be operating on a lot of the other side very frequently. And I don't think there's an emergency associated with FAI or labral pathology. I will let athletes go through a season with FAI and then manage it afterwards. I'm okay doing injections and things like that because I think overall, the hip's going to tell us if there is damage going on in most cases. This was another case, last case, 18-year-old freshman collegiate soccer player, mild pain in the groin, right in the left. And again, very mild. This is his radiograph. So really big, kind of gun stock deformities, cam lesions of bilateral hips. I talked to him about it, said, look, this is a problem. You're probably going to need surgery at some point. Just knowing, how long it's been going on, the deformities that you have, the type of activities that you do, probably going to need to do something at some point, but it's not bothering you that much. He could compete. It didn't feel limited by his hips. I said, look, go, you can play the season, and then we'll manage this after the season, as long as you're not having significant pain during the season. I don't want you to play through pain, but I'm okay with you playing with this as is. And the doctor at the school had a different opinion on him. Told him, no, your hips you're going to go on arthritis if you do anything more on this, and you really don't need to be playing with your hips looking like this. And I told I think the big difference is if it's asymptomatic or not. If he has symptoms and he's having a lot of pain in the groin, that's one thing. But if it's really a little bit of soreness, he's mainly just trying to get an answer. Yeah, I've kind of had a little bit of issues with my hips for a while. I want to know what's going on. And he's not having that much pain. I'm okay with him going through the season. I wouldn't recommend necessarily doing that for his entire collegiate career or whatnot. But there's no urgency I don't think the evidence is there to say that this is an emergent thing that needs to be treated immediately to prevent damage or arthritis of the hip. All right, with that, I'll take some questions. I really appreciate the time being able to talk to you all. Here's my information. Please use it. You can take down my cell number, call me, text me anytime. It's my email and then my office number as well. Probably the easiest way, if you have a patient that you want to see me, shoot me a message on my Epic inbox, or you can text me, you can call me. Those are probably the easiest ways. When you call the office, you might, it's going to be hard to get just one person. I don't really have a mock or anything like that. So really most of it, if you just send it directly to me, that would probably be the easiest way to manage it. All right, so I can open up for some questions. I think we got a little bit of time left for questions.
Hi, Alex. Can you hear me? This is Mo.
Yeah.
So, well, sorry about the background noise. I'm at the airport now, but I wanted to say this is a fantastic talk. A lot of us encounter these patients, and I think it's very important for us to have the same dialogue, or more or less the same discussion, before we send them to you. That way they have the right expectations, especially with patients with FAI. One thing that I wanted to mention, that physical therapy can be somewhat challenging, particularly when the problem is more of a mechanical problem. That said, there are patients who have increased anterior pelvic tilt, and that can be really addressed with physical therapy, and they do typically well. This can be habitual, or this can be because they originally have poor spine pelvic mobility, and addressing this with physical therapy can be somewhat helpful for some patients, particularly those who are not high level athletes, or they don't necessarily play certain sports like soccer or football, where they really need to flex that hip. But this is something that can be looked at. It can be still more challenging if the patient also has back pain issues and has stiff lumbar spine. Then in these situations, and I think my physical therapy colleagues can attest better to that, I think it's also important to address the lower back pain along with the hip pain, because otherwise you won't be able to retrain them to improve their spinal pelvic mobility and biomechanics. But again, thanks so much. This is super helpful.
Thanks, Mo. Yeah, that's awesome. And I think this, communication is just critical. I think the what you all bring to the table, and just working together as a team is the way to manage these patients. And really, patients are looking for an answer. They're looking for a diagnosis, and they're looking to get better. And I think the only way to do that is if we do it together. And so sending patients back and forth, we each have our unique toolbox on this, and it's really satisfying to see patients get better and to be able to do it together.
Alex, again, great talk. This is Ken from Rehab. I just had a question on your thoughts regarding, joint supplementation, like glucosamine chondroitin supplements, and there's some evidence with it with regard to knee pain and knee function in the arthritic knee. But I was wondering what your thoughts were with regard to the hip.
Yeah, I get that asked a lot. I think in the literature and stuff, I don't think there's a lot out there in terms of support for that kind of moving the needle in terms of preventing damage or things like that. But at the same time, I see patients, like, a lot of times they'll ask me, oh, should I take this? Or I feel better when I take collagen, or I feel better when I take glucosamine. And I say, look, we don't know definitively that that's helping, but I don't think it's hurting. And if it makes you feel better, if you feel like it's, that's kind of helping to benefit your health and the health of your joint, then I think that's totally fine. Honestly, I don't know. I think there's a lot that we don't know. I do know, like with collagen, for example, I'll tell patients, look, it's getting broken down into those components. It's not just staying collagen and that's just like being used by your body. It's going to be broken down into, amino acids and things like that. But maybe those are amino acids that you need that you're not getting otherwise. So maybe it turns out just being a way of vitamin supplementation or getting in, extra protein in a certain way that you weren't getting before. So, I that's kind of the way I usually address it. I don't think it really pushes the needle. It's not something that I actively tell patients to use or whatnot. When patients ask me about what are some natural remedies and things like that. I like turmeric a lot. I think turmeric's a good, natural anti-inflammatory. I'll tell patients about that one. CBD oil and things like that come up a decent amount, and and I think that's okay. So, but that's just like a dialogue that I'll have with the patient, and just be very open with the patient. I don't want to, if they feel like they're, I don't want to be too scientific about it, because again, I think it's a little short-sighted. We don't always know what is and what isn't working, even if the data's, out there.
Thanks. We're very similar conversation. So just making sure we're on the right track. Thank you.
Hey, Alex, this is John Dale. I'm a physical therapist up at Whitemarsh. I was wondering if you could just quickly speak to maybe how your approach changes clinically or in surgery when you get a patient that's maybe had 1, 2, 3 previous labral repairs, and how your approach is different with them.
Yeah, that is a difficult problem, and I see some of that. I think the main thing that I'm looking for is kind of, again, why do we think this is going on, and what's the underlying cause? The literature would show that the main reason is that under resection of a cam lesion or under resection of the bone. Other times it could be that if the labrum was maybe resected and the bone looks okay and everything, and it truly is a more of a labral issue, and maybe they need a labral reconstruction or whatnot. And then the last one that really we're starting to understand is that over resection of a cam lesion or subtle instability of the hip and things like that, how to manage the capsule. For example, I had a patient had a hip arthroscopy done, an excellent hip arthroscopist that I know, and they did a great job, but the patient ended up having a tear in her capsule. And so on our arthrogram, you can see how that fluid is kind of coming out of the capsule, and she had signs of kind of hip instability of her hip. So we ended up doing an open capsular reconstruction of her hip, and she ended up doing well. So again, those are the type of things you just have to dig a little bit deeper on what's the source of the problem, and really trying to understand that. And the other thing is this, if you did the surgery before and the surgery went well and you addressed everything, the other question that you have to ask is that is the pain coming from the hip? Is the hip the main etiology of the pain, or is it just a fact that it's maybe a spine issue or something else, like this patient that I saw yesterday? I had more suspicion for something going on outside of the hip versus a problem with, maybe they retore their labrum, or maybe they didn't resect the bone enough. So that's kind of how I approach those cases.
Dr. Johnson, this is Sam Runfull. I'm a physical therapist with NovaCare Rehabilitation. Can you just expand a little bit, on the challenges of some of those folks that have the, a cam or a pincer lesion that would lead to, obviously some mobility issues, but also have an underlying hypermobility, and how that changes your thought process on your surgical approach, the decisions that you make leading up to that?
Yeah, no, that's a great question. I'm glad you brought it up. I think these patients can sometimes be a lot more symptomatic because they're able to get their hip into positions that other patients aren't. And even if they don't have a big cam lesion or a pincer lesion, sometimes I think that having that ligamentous laxity in a dancer or whatnot, they're essentially subluxing the hip out of joint, and that's putting tension on that labrum and can tear the labrum. So my approach to those patients is, one, is just making sure there's no bony morphology that would kind of lead to instability. If there is, then I'm really, really careful about that and going towards more of a PAO or something along those lines to address that. The other thing is, at the time of surgery, if there is hypermobility going on, patient with Ehlers-Danlos or whatnot, I take really extra time to make sure I'm closing that capsule really, really well, maybe putting extra stitches in the capsule, tightening up the capsule nicely, spending really, a lot of time defining the capsule so that I get a good repair on that. And the last thing that I'll do is I have different protocol for instability patients. So those patients, I will limit their weight bearing for a little period of time. I'll keep the brace on for longer, and then limit their motion a little bit longer. So allowing that capsule more time to heal, and before we start stressing the hip, and allowing that hip to really tighten up a little bit in those instability cases. So when you see my protocol, I'll give patients that have instability, they'll get a different protocol from the patients that have the normal accelerated protocol that I'm usually not worried about that.
Great, thank you.
Yes, we all finished up. I think Dennis might have popped out and had to go in the OR. Oh, I think if nobody has any more questions, I think we'll probably close it out. But I really, really appreciate everyone's time and your attention. And again, reach out anytime you have more questions or anything, or issues with patients, concerns with patients. Feel free, call me, text me, and you'll be happy to talk anytime and work together for these patients. It's fascinating stuff. I enjoy doing it. So again, reach out anytime.
Thank you so much, Alex.
Thank you.
All right, y'all take care.
Thank you.
Thanks, Dr. Johnson.